Q&A session. We do these for our folks and the folks that listen to our stuff so that we can dispel some of the rumors that are going on out in the industry and also give an opportunity to give answers to questions that folks have sent to us or that we've seen and give you guys the opportunity to get those answers. Before we get started, I wanted to mention that if you guys have any questions that pop up during the presentation or if you brought a question with you, please put it into the Q&A box. That way we can keep a record of these questions, and if need be, you guys can have that as a reference for later. We will be providing a recording of this session as we have every time, and it will be sent out as well as be housed on our YouTube channel. So if you haven't had the opportunity to check out our YouTube channel, please do. We can provide that link. I will put it in the chat box during this session. That way you have the opportunity to see not only the Q&A sessions that we've provided in the past, but also podcasting that we've done on some hot button issues. We call our podcasting unfiltered productions because we tend to get a little bit unfiltered, and it tends to get a little bit entertaining for us and hopefully for you, because it's hot button things that maybe we need to have an outlet for and have a rant for. So Cindy, are you ready? We can get started with our first questions.
I'm ready.
Okay, here we go. This is going to be a hot button issue, and it's continuing to be a hot button issue. And I'm going to start with the confusion about OTs and the admission. Just as a side note, the public health emergency was extended this week for another 90 days at least due to the COVID-19 pandemic. And that means that the waivers that are in place for the COVID-19 pandemic continue. So Cindy, if an OT and PT are ordered, this is the big question, and then I'll let you go into this in a little bit more depth. But if they're ordered and the OT does the admission, does the PT have to make the visit the same day?
Well, I think that seems to be kind of the heart of the issue. And for some folks, you may now say, well, oh gosh, this just, Cindy's explanation is going to be kind of long. I can already hear her winding up. I'm trying to put as much information out about this as we can, because people are seeking out answers to questions in a variety of places. One of them that seems to have seen a big increase is on social media platforms. And when I see these questions, like the one Sherry just asked, get posted, it's almost scary to see the variety of answers, the inconsistency of answers, and how the fact the answers don't usually have an actual resource attached in terms of a CMS official resource. And so as many of us as can get on the right page about issues like this and be able to provide clear information to the people we come across, the better. Because that question you asked, Sherry, is exactly what's raising its head right now. This idea that, okay, we understand that OTs can do admissions now, but that also means that PT has to go the same day. So let's just cut to the chase on that. There is no CMS source that validates that opinion. Okay, there's nothing we've seen in the waiver. There's nothing we saw in the final rule for 2022 that stated that PT or speech, for that matter, had to go the same day as OT if they did the admission. Where do we think this came from? Well, what I'm trying to get, oh, go ahead, Sherry. I heard you inhale.
I was just gonna ask you that question. I think that this is something that lives from an old source. So go ahead.
Well, it really is about putting it into three separate areas. Bucket number one, pre-COVID. Okay, so we knew full well before COVID, in the days gone by that seemed like a long time ago, sometimes a lifetime ago, we knew OT could not admit traditional Medicare patients. Okay, that they were not considered a qualifying service. We knew that if nursing was ordered as part of the care plan along with therapies, nursing had to do the admission. And that if therapy only, a term I'm not real fond of, but if therapy was ordered without nursing, PT could admit, speech could admit, OT could not. You may be saying, already know that, why am I here today? Okay, well, but wait. In those days, we had a phenomenon of PT being ordered without nursing, but not doing the admission. So either the therapist, and I hate to say this, Sherry, because it still happens today, the therapist refusing to do the admission, arguing that they're not capable of doing this, or a contract situation that says, nope, I'm not doing admissions. That's just not in our contract. Or agencies that have decided PT is not qualified or competent to do this. So we are going to put a nurse in on everybody. Okay, now understand, an agency is making a decision for whatever reason that they are putting in nursing despite the fact nursing was not an ordered service from the physician from the beginning and is not a needed service. They are simply going to go out there and do an admission visit for therapy. Now, because nursing is not actually going to be part of this plan and it's essentially a workaround, nursing going out to do this single visit to admit the patient is not considered a billable visit. So I can't use that date the nurse goes out as the start of care date because that coincides with the first billable visit. The standalone workaround is not going to cut it. So this is why we see the discussion of PT going the same day as the nurse, because then that makes the start of care date match that same date as the nursing visit. So let's keep in mind, that was never a, here is the plan from CMS, how to admit patients in home health. It was a specific workaround that led to this, you got to do it the same day. Okay.
Cindy, can you elaborate a little bit on what that waiver says, not just revolving around OT, but also what it says about who can do the admission and when?
Well, before we get to the waiver, we got ye old days. Now let's talk about current days without the waiver. Let's put the waiver to the side for just a minute. Starting in 2022, they capped a portion of the waiver and converted it from temporary to permanent. And that permanent shift was in the cases where nursing is ordered along with therapy, nursing still has to do the admission. That did not change. We went where we've always been from a rule standpoint. If nursing's ordered as part of the plan of care, they're doing the admit. But what did change was if a multiple therapy case exists, so OT with PT, OT with speech, or all three, OT could be the one to do the admission for this patient. That is the regulatory issue. And if you look at the rules for 2022 and the conditions of participation that were updated in late 2021, that is exactly what it says. That is the rule. The waiver you referenced, Sherry, is still in play. And we just got another 90-day extension, so it's still going to continue to be in play. The waiver didn't change the rule. That's the fundamental issue. The waiver is seen as a temporary thing related to the public health emergency. And the waiver still says that if nursing is ordered along with therapy, any of those services can do the admission. So the nursing has to do it requirement is not in the waiver. And again, if nursing isn't ordered, then it becomes a non-issue. If there's multiple therapies, OT can be the one doing the admission in that case. So what is the confusion? I think the confusion is people, when you ask CMS in particular about certain things, you have to think about the words you choose because the regulation says what it says and was updated in 2022. The waiver is not the rule. The waiver is a temporary situation. And Sherry, I believe this whole, well then, because OT still is not a qualifying service, that's true in today's regulations, and that didn't change in the waiver. They didn't change their status about being a qualifying service. People are taking the old workaround for putting a nurse in on a PT admit and applying it erroneously here to say, well, if OT is not a qualifying service, then the only way this is going to work is PT or speech has to go the same day as them. Now, go ahead.
We have a question in the chat box, and I
Yep.
wanted to just reiterate, please put these questions into the Q&A so that we can keep a record of them. But I'm going to go ahead and ask this question because it is one that we definitely need to clarify. Just to clarify, outside of the most recent waiver, if skilled nursing and PT are ordered, the skilled nursing must be the discipline to do the start of care.
Correct. And the regulation, if you look at the regulation, that is what it said pre-COVID, and that's what it says now in 2022.
Right. But does the waiver still stand that no matter who's ordered, that the most appropriate discipline can do the admission? Does that still stand with the waiver that's been extended that started in March of 2020 and has been extended another 90 days?
Yes, There has
Mhm.
been nothing. All we've been getting is waiver extensions. There has been nothing added or removed specifically from the waiver. There were just a couple of elements, that and the physician assistant nurse practitioner piece, that they shifted out and moved into permanent regulatory language for 2022. But the waiver is still in play.
Thank you so much, Cindy. And that's really something that we need to think about, because now that we're going on, almost 24 months of the waiver, it starts to feel like regular everyday practice. But we need to understand that we're still under a waiver, and those special exceptions in the waiver are still there. And I know that some folks have maybe just started in home health in the last couple years, and they feel like this is regular practice. Hey, we get to do this from now ad nauseum, and it's just not the case. So we just need to pay attention to what's coming out of the Department of Health and Human Services, and knowing that they're extending these by 90 days. So kind of how the disease process goes is when we're going to finally get off a public health emergency, and at that point we would have to return to what it says in the 2022 final PPS rule, as well as the conditions of participation. So I just want to be really clear with that sometimes if you stay in something long enough, it feels like the norm, and we are still under the waiver guidelines. Cindy,
And
what
and
kind
Sherry,
go ahead.
before we leave the OT topic, there's a couple other pieces. I think it's a good example of how we need to be very careful about word choices. Are we talking about regulation? Are we talking, about the Medicare benefit policy manual? Are we talking about conditions of participation? Are we talking about a state rule? Are we talking about the waiver? I think sometimes we lump all that into some sort of rules, amorphous rule category. And then that tends to get us into trouble in terms of what is actually expected of us. And we tend to see situations where maybe something was a rule 5 years ago, or maybe something was an agency policy, which was more stringent than the rule, but it's not the actual CMS regulation, that we have to always look for credible source documents when anybody's telling us we have to do something. And that's what I've been trying to encourage folks that have taken their questions, whether it's OT or other things, to social media platforms to say, yes, you're looking for opinion, and I'm not being negative about seeking it that way, but if someone's giving you a directive about a regulation, it needs to come with a source, because there's a lot of people saying you have to do this and you have to do that, and I know this is a rule, but can't actually produce a source document. And I think, people on this call have probably heard me say it before, and I know you have, Sherry. I swear in our industry, for every real rule, there's 5 fake ones. Not bad ones, but misunderstood ones or old ones or outdated ones that people want to die on a hill that they're still real, even when you can't prove it in any sort of current document, current CMS source documents. So I tell people that just because Cindy Krafft said it doesn't make it real either. We have to look for those source documents. And sometimes when we dig and we dig and we dig because we know something's true and we've checked every source and can't find it, maybe we have to say, was that an agency policy? Was it something I heard at a webinar? Maybe it's not the regulation. It doesn't mean it's not a good idea. Maybe we do keep it as an agency policy, but we want to be real careful about this because we have enough things we have to be compliant with without making things even more convoluted. The last thing briefly, Sherry, though, is sometimes we really do need to ask CMS a question. And in the discussions around OT, I think there is a situation we don't really have an official CMS response on that I've encouraged folks to ask them this. And that's a situation where, let's say, Sherry, I've got orders for PT and OT. And I look at the situation and OT is going to go do the admission. So they go out and they complete that admission visit. Now, the PT calls the patient to try to set up an evaluation, and the patient adamantly refuses. I don't want this. I don't need this. You cannot come to my house. Now, realistically, that should be a rare occurrence. I believe we need to do a better job across all disciplines explaining to the patient what we do, why we do it, and why it's important. Not like, oh, good, you refused because I have 10 more waiting, I'll move to the next one. But if we truly get into that situation, PT is not going to be allowed in the house. What do we do? Because we don't have a qualifying service. OT did the admission, we don't really have a defined answer. So Sherry, based on current rules, and as a former agency owner, what would you say is the best move in that situation until we hear an actual confirmation from CMS?
Since OT cannot qualify a person as being appropriate and certified for home health care and the Part A benefit, I would have to discharge the patient. Nobody wants to hear that. Nobody wants to
Right.
do that, obviously. But if you don't have another skilling service for the initial cert period, then you have to discharge that patient.
But again, I think, should it be a routine occurrence? I would not expect it to
No.
be. I would think that a patient who is in that much need for OT and is homebound as would benefit from at least an evaluation from physical therapy, and an evaluation, even if it was an evaluation only from PT, it properly documented would confirm that qualifying criteria and you could continue. But if you can't get a qualifying service through the door, no matter how hard you try, the only option you're really left with is to not continue care because you don't have a qualifying service. So that, to me, that question warrants further discussion. The I know somewhere somebody told me that if you send OT, PT has to go the same day. Not only is that not in regulation, I would not suggest we suggest that to CMS, because honestly, Sherry, if that actually turned out to be the case, what's the point of OT admitting anyway? I mean, if I
Exactly.
got to send PT the same day, this is not even in the waiver. That's not helpful. If I would have to send OT and then a nurse the same day to make this work, then I would have just had the nurse do the admin.
And Cindy, we may have some OTs on this call right now that are actually applauding you saying, well, why send OT to do the admission anyway?
Well,
One thing,
unfortunately.
and I want to clarify something there, we hoped that somehow we would get some movement on OT being able to be a qualifying service during the comment period for the latest PPS, but CMS reiterated that is a congressional mandate that would have to go through a law change for that to occur, and that's unfortunate. I think that it was probably, and this is a myth that'll get out there probably, Cindy, but I'm going to say it. I think it was probably a typo or an error when that law was written. However, it is law, and therefore another law would have to change that, and that's why OT cannot be a qualifying service on the initial certification period. They can qualify services to continue at research. Just to make it more confusing, I thought maybe I would mention that. What do you think?
Oh, no, it is. It has been attributed to a grammatical error, Sherry.
Yeah.
You can see where it also has manifested itself in outpatient, where PT and speech have to share a payment bundle
Hmm.
essentially, and OT got their own. That is because of placement of a comma, which was PT, comma, ST, and OT. And the use of the word and somehow separated them in somebody's mind as different. And we've seen that with respect to the issues around the qualifying service as well as in outpatient. And I've seen efforts to try to fix that, Sherry. And what boggles my mind is part of it is CMS's formula about the utilization, the costs associated with the utilization of aid services based on the qualifying service. So the cost, additional costs beyond just being a qualifying service. And I find it laughable/disturbing to say that making OT a qualifying service would increase the cost of the aid. I, of all the services to say would cost more for the aid, to say it's OT is lunacy. But
It
yeah, it
is
will literally
lunacy.
take an act of Congress to fix it.
So what training would you recommend to get OTs ready to be full members of the admission team, as far as doing the OASIS and establishing the plan of care and those kinds of things? What training do you suggest for that?
Well, I think it's important to separate out a few things and look at the skill set of that individual OT. Has this OT been doing research, resumptions, or discharges for your organization? If that's the case, then the idea that to do an admit, I have to put them through some long-winded OASIS training is probably not practical or necessary. There are a few items that are specific to the start of care that you could hone in on, but I wouldn't think that they would need full-blown training if you've already deemed them competent with respect to those other time points. I think the bigger issue, because I've had people reach out and ask about training OTs and they keep saying OASIS. It's turning out it's not really OASIS. It's the rest of that comprehensive assessment issue. They know how to do OT evals. They better know how to do OT evals. And if we already have, 75 to 90% of the OASIS already under the belt, then the issue is what is the rest of that comprehensive assessment going to look like? And I think the best way to manage that is to have the OT do some visits, some co-visits with your strong RN, with a strong PT who's doing admissions. If you have enough speech have them involved in this space and they're proficient in that, them as well, to get a feel for what are those other things. Because I think that's where a lot of PTs had roadblocks in the beginning, and some do to this day. We're fine doing evals. Okay, Oasis is Oasis, I get it, but what else do I have to look at? And sometimes EMRs tee it up in a way that says, okay, I'm not just going to ask if your pain medication has made you constipated. What comes up on my screen is an entire bowel and bladder assessment with color and odor and all this other stuff that feels way out of my scope. So then I dig in my heels and say, I can't possibly do this. I'm not a nurse. So we've come a long way with PT of helping to navigate what needs to be the comprehensive assessment. What isn't, I'm doing everything exactly the way the nurse does, because I'm not, but I'm looking for issues that may warrant a nurse. So helping the OT understand that piece is a critical element. So I just don't think it's a knee-jerk reaction to put them in like they just started with you and let's do Oasis 101, unless they've never touched one for you, and then that absolutely needs to be a part of it. But I think the bigger bridge is what is that third leg of the stool between the eval, the Oasis, and what makes the rest of that comprehensive assessment. And I think by going out on co-visits with your strong clinician can really make it real life applicable quicker than necessarily classroom scenario type setup for them.
But we also have some training on MedBridge
Mhm.
that shows a patient in the house. It's very
Yep.
accessible in small bites that will help with the training on that. So if you go to medbridgeeducation.com, I think it is, Cindy, and I'm probably misquoting that website, which could get me in trouble. But you can find some really good Oasis, easy to get information that you can
Right.
train folks that are just starting in home health, not just
Correct.
your OTs, but everyone else. I
Mhm.
wanted to reiterate that if you have any questions that pop up into your head, or anything that you'd like to get, any myth you'd like to get dispelled, please put it into the Q&A box, and we will get to as many of those as we can. So I want to get you teed up here on one of the myths that we hope to completely dispel today, Cindy. And I mentioned earlier that the public health emergency was just extended 90 days. So it's set to be relooked at, I think, on March 16th or thereabouts. And that announcement will come from the Department of Health and Human Services. So does this impact the start of Oasis E?
No. And I thought that was almost, I kind of chuckled with the Q&As that just came out about Oasis for January, that was question number one at
Yeah.
the top in bold. And I think CMS had to do it at some point, because the confusion is that the statement about Oasis E starting January 1, 2023 was pretty much buried in the proposed rule and the final rule. So I think a lot of people are still associating it with the waiver. So I think, the Q&As have a definitive, it is starting January 1, 2023, independent of whatever happens with the PHE. Now, I don't want to say anything, jinx anything, cause anything. There could be something that happened that potentially would delay it. We don't know. But at this point, all indicators are nothing is going to stop this from going live January 1, 2023.
When did they start developing Oasis E, Cindy? Isn't it kind of almost an old document at this point?
Yeah, it's been a while. And for those of us, you've accused me of this, as has Dee, that I sleep with that thing under my pillow. It's felt like a long time coming, because there are some questions that just don't do us any good. I mean, the vision question has been sitting there for 20 plus years with the same responses, the same confusion, the same lack of sensitivity in that item. And because it was payment driven, it was part of how we used to conduct payment prior to PDGM, and it just sat there. So Oasis E was meant to clean out some of that stuff that was just either not particularly useful and get us better questions in several areas. So the problem is with the delay, I think people lost track of it as well. And I totally get it. I mean, the pandemic has reorganized priorities all over the place. So I totally understand that Oasis E, when we got told it was going to wait and wait and wait, we just moved off from it. But I think we have to now be have it on the radar because it's going to come back. They're going to re-release. It says potentially this month. We'll see. They address that in the Q&As as well, that they're going to put it back out for comment and then ultimately a final version. So whether we like the idea or not, whenever we have an opportunity to review something, to give any sort of feedback, I'm somewhat impressed they're doing this again because they did come out of the gate with this before when they were going to originally do it and then had to pull it back. So it's almost like they're giving us a, we know you haven't thought about this in like 2 years. So we'll put it back out there again if you have any thoughts about it.
And I just want to mention that we have a page that's dedicated to the transition from Oasis D to Oasis E. It's under the education tab on our website at www.valuebeyondthevisit.com. And we also have a counter on there. So as it stands right now, we have 346 days left to train for Oasis E. So start training now. And we did a survey, and part of that survey was to ask people if they planned on training Oasis D in preparation for Oasis E. So Cindy, would you suggest that as a tool for folks to get into Oasis E?
I would. I think that we just have a long track record in this industry with Oasis in particular to kick that can all the way down to the fourth quarter before we start a new tool. And there's positives to that because anytime there's brand new questions, why am I going to teach that stuff a year ahead essentially? Because if the clinician doesn't get to actually use it, they're not going to remember it. So I wouldn't say, because I'm hearing from some folks, Sherry, that they've started, training the new items now. And it's like, okay, maybe from an initial exposure, but I probably wouldn't drag too many people in my current short staff situation to talk about the new items that they don't get to use for 10 months. But we have to remind ourselves that the bulk of this tool is the same old questions. And our nemesis of both the M version and the GG version of functional assessment are going into E exactly as they are today. And I know I'm preaching to at least several members of the choir that know that that's a section of repeated education, of back and forth arguing, reviewers saying, how many times can I make these corrections? Clinicians who agree to the corrections to make the document move on, but now I have to make these same corrections every single time these charts come in, which causes rework and expense. I believe Oasis ePrep is getting D issues under control now, especially when we're talking about areas that directly affect our payment rate at the moment, as well as stuff that's teeing us up in value-based purchasing. It's a multi-factor issue that says if I can get my Oasis correct now, then yeah, in fourth quarter, we're going to talk about new items with the clinicians because this is getting much closer to when they can do it. But then it's only 20 or so items I've got to deal with then, not the whole thing, not hours and hours of training. And I think, Sherry, that's what has driven our development of an Oasis test, not to make certifications or letters, but to help agencies get in real time an idea of what their clinicians know and don't know so that we can focus training. Especially in the current environment, we do not have time to haul people in virtually or otherwise to come to training that some of them don't need, or sessions where half of it they didn't need. We need to focus in on where those gaps are. And if it's a few individuals, then bring those few individuals in and get this fixed. Don't bring in the masses if we don't have to, because that helps us be efficient and then to be more confident. Because again, these items in our, what did you call it last time, Sherry? The value-based purchasing, was it spring? You had a
It's
sports analogy.
it's the rehearsal. It's spring training.
Right. So I'm already in spring training for value-based purchasing. So I don't want to wait on these items and do a refresher in fourth quarter of this year. In my spring training year, I want to make sure this is all under control before we get that close.
100%, Cindy. And if you want to, guys, if you want to incentivize your employees and your frontline staff to get these items correct at the jump when they first see that patient, tell them that if they get it correct, they don't have to attend any other trainings. It's simple.
Uh-huh.
I think that would make everybody happy, and that would make people understand that hey, you have a way of getting out of these mandatory trainings. Just get it right the first time. Imagine that.
Mhm.
A couple things about Oasis E, Cindy, that have been bantered back and forth is there's a bunch of questions that are a little bit different than Oasis D, and it's regarding the social determinants of health, like transportation and access to food. If we find there are issues on there that surround these, do we have to put them on the plan of care?
Well, have to is an interesting word. I think it comes down to if we're finding issues that because the question about transportation as an example reads, has lack of transportation kept you from medical appointments, meetings, work, or from getting things needed for daily living? That's a pretty important question. It's not, hey, I wish I had a car. It is, has this prohibited you from getting things that you need? If I'm identify an issue for this individual, I would think as a healthcare professional, as a healthcare entity, I would want to do something about that because that could have a negative impact, not just on our plan of care, but as well as how well this individual is going to do, or what other issues might they be having. So I'm hearing people already use that word. If I find this, do I have to? I think we need to reframe it a bit and say, okay, before we go down the rabbit hole of making more standardized interventions, that we're going to make pathways, that we're going to take the transportation question, then depending on your answer, here's the interventions we're going to put in the EMR, and then here's all the goals about it for the nurse to do. Oh, wait, nurse isn't involved. This is what the therapist is going to have to do. I think we're forgetting something. What about medical social work? I've been in this setting now for over 25 years, and I have never been able to wrap my mind around the small utilization numbers for social work. And I've seen enough agency data reports to say, also, when you figure out your cost per visit with the few visits that they do, it's astronomical at times
Hmm.
compared to what you're paying for clinical services. So I would say before we just go down old paths of saying, well, this is more stuff we're going to have to put on the admitting clinician, to say, why would we not take some of those issues and plug this into a social worker referral? I've thought that for some time now, and it expands it in eSherry. There isn't just the 1700 question about, cognitive functioning or confusion or anxiety. They're elaborating it into, should a brief interview of mental status be done? Are there signs and symptoms of delirium? Does this individual have issues with social isolation? Okay, so could social work be helping us out in these areas or helping out a family figure out, yep, he does have these issues. So what are the resources? What's the plan for when we don't come anymore? Because I'm going to soapbox a little bit, Sherry. I have
Go
never,
ahead.
also never understood why that social worker order happens in like week 6, 7, or 8. It's almost like, oh no, now the patient is upset that they're going to lose the aid. Now we'll get a social worker order because they live alone. Wait a minute. They lived alone when you admitted them. We have an OASIS question that already indicated they live alone. So why is it at the last minute we now realize we're about to be done? We cannot continue to justify services on the skilled, reasonable, and necessary. Wait a minute. Now we'll get a social worker. So I think the discussion around those social determinant of health issues that are now coming into E need to challenge us to not just make an assumption or, in our short staff situation, continue to overwhelm that admitting clinician with this idea that everything I find is somehow my responsibility to fix. But my job is to screen for a variety of issues. And if my screening indicates there's a problem, social work can be a huge help in figuring out what are the community resources, providing support to the family, helping them navigate. I, I just don't understand why the knee-jerk reaction is, oh gosh, we're going to have to make all these new elements of our care plan. We're already building it, and we're going to stick it on the nurse. Because I just don't see where some of these make sense to do it and why we wouldn't utilize our social work more. And I can't believe I'm going to say this, and I know this is being recorded, but for all the hypervigilance about monitoring for LUPAs, and we don't want LUPAs, appropriate utilization, they count in the visit count to have a social worker. So why it's so rationed, I just don't, I've never understood that. And this seems like a good opportunity going into E to revisit that idea with some concrete items that could trigger why we're having them come out there.
Absolutely, Cindy. And it's real important, especially with the hiring issues that folks are having. And we hear you about the hiring issues for nurses and aides. We need to make sure that we're utilizing all the services that are allowed under the Part A benefit. I think that we have underutilized occupational therapy throughout the years. I will preach that till the end of my days, probably. And I know that we underutilized the use of the medical social worker and dealing with some of the family issues that we read about every day in narratives and documentation, Cindy. We read about how difficult some families can be and how difficult living situations are with folks. And we almost never, and I'll tell you, very rarely do we see a medical social worker documenting their involvement. And I think that it's time to relook that as agencies and take advantage of some of those things that the Part A benefit allows. So Cindy, I know that you're hot off of a technical expert panel call. So I'm going to ping you a little bit with a little bit deeper dive into Oasis E with this question. The GG items are continuing in Oasis E, and you know this is something that we all know this, but we all also maybe don't remember that it's part of the Impact Act of 2014. Cindy, am I getting that right?
Yep.
This is law, you guys. The GG items and the things that have been added to Oasis D along the way, and moving into Oasis E is absolute law because they're trying to set up a continuum of documentation between all the post-acute settings, between skilled nursing, inpatient rehab facilities, and home health. So those items are still going to be on Oasis E, and sometime in the future, you're going to see more and different items. So what is the purpose of those since we already assess function with the M1800s? I know we see some disconnect between the answers on the M1800s and the uh, GG items. So can you elaborate on that and you know explain what that purpose is?
Well, you're absolutely right. It is those are in there because those are the exact same items, the verbiage, the guidance, all of it. The same for home health, for skilled nursing facility, for inpatient rehab, and several of the questions are also in LTACs, long-term acute care hospital. Um, in the short term, I fully understand, and many people will say they don't match the M version and the GG version. It's not a one-to-one relationship. The bathing question in the M, as an example, includes the transfer. In the GG, it excludes the transfer. I agree. There's not an exact match, but there needs to be some degree of harmony between those responses. And I think what happened early on with this is, well, you know, this doesn't affect our payment. We're not having any of our outcomes currently measured by this. It's not in value-based purchasing. So, you know, we heard many agencies just kind of let it go. The only thing was, you know, put something in there because there was a measure related to at least answering the questions. We did see in the most recent Q&As for this month, several questions about GG. But, you know, as we do our outsourcing and I look at it, it's like, you know, hello, is this even the same patient? Because it looks like the patient has a significant amount of impairment in the M version, which drives payment and influences outcomes. And in the same assessment, the GG ones say they're 5, which means the patient only needs assistance before or after that activity, but the activity itself is safe and independent. My concern in the short term about that inconsistency is because it's payment related, have we been submitting documents that could be viewed in hindsight as gaming? That you scored the M version more aggressively because it's payment and you let the GG go. Yeah, that fits for our setting, but I'm now in my second round of technical expert panel call. And trust me, I can't divulge documents. I can't do anything because, you know, you're sworn to your secrecy. But what I can tell you is that our data has been collected on GG, and that frightens me with the number of folks that have said, yeah, you know, we told them to try, you know, try hard early on. Yeah, nothing's really happened with it now. It seems like we don't get invested in Oasis items until there's a very clear, this is what it's going to do to you. And then we create data that goes, you know, along one way. Then suddenly, if somebody pays attention to it from an outcome or a payment standpoint, we become very good at those items, which then CMS looks at it and says, well, what were you doing before this? Because I thought you were answering them correctly before. So on this technical expert panel, the SNFs and IRFs have been doing this for several years. Anybody who remembers the impact graph and the phasing in of these measures, home health was always last in terms of sequence because we have our own unique characteristics. So start it first in the SNF and the IRF, and we'll add home health measures over time later. So here we are today, and we have the same measures as SNF and IRF. The thing is, SNF and IRF have been filling these out a while, and they're already moving to the point of changing the metrics. Are some of these questions, because the initial model looked at all of those GGs. Now they're saying some of these are not appropriate. Maybe we should take them out of the calculation. Maybe we should combine things. Maybe we should add this. Maybe we should change what the value is when someone chooses a not attempted code. The scary part is we haven't really seen publicly released information about GG measures in our setting. So they're approaching it from a post-acute standpoint of all. I mean, I'm not disrespecting LTAC, but that's a small percentage of this, of the big three. And they're prepared to refine the measure, even though we don't really have hard home health data. So I don't know, Sherry, as we have a few more meetings as a group, I'm hopeful we get to lay eyes on some home health data, but it concerns me that years have gone by with GG in there and CMS is preparing to call that our official baseline when a portion of our industry has not really paid that much attention to it. Excludes it from their internal review process, says, why am I going to spend time on this? I'm only focused on the PDGM items. I'm concerned what that means for us in the future, because I've always tried to get people to understand, Sherry, CMS believes our answer is 100% of the time. So whatever we put in there, even if we thought we had some sort of free pass period, that's all been getting warehoused as accurate information about the home health patients.
And Cindy, I want to just add a regulatory issue that we've come across recently. When you see those disconnects between the functional items, the M1800s and the GGs, many times it's due to a regulation that we've kind of been seeing being skirted a bit. And I want to caution everybody on this call that it is a regulatory requirement that the clinician approves changes to the OASIS document. This is confusing, Cindy, because they in I think 2020 or 2021 they started allowing collaboration on the OASIS document. But ultimately there's a signatory on the OASIS document, and it is a clinician who owns a license. And the regulations are very clear that the final say on that document belongs to the clinician. And something that we've noticed in our travels through this universe is that many agencies, and I say many because, and again, it's many of the ones that we've interacted with, have started to kind of skirt that and have allowed the OASIS to be quote unquote fixed and then submitted, and totally cut the clinician out of that review process. What do you think the risk is with doing that, Cindy?
Well, first of all, it's a compliance issue that
Yes.
if you got surveyed and somebody, figured this out, that the clinician was not signing off on the changes, you're right, it is a regulatory issue. And I understand a clinician will probably find it convenient if somebody said, I'll just fix it for you because they don't like OASIS and one less thing to deal with. So I go back to what you said earlier, Sherry. If you did do it right the first time, there wouldn't be corrections either, and no education you'd have to go to. So double win for the clinician to actually do this correct. But the clinician may not step up and say, you can't do that without me. Sometimes we do. Sometimes we hear of clinicians that do that, but they're often labeled as difficult. Why won't they just accept the changes? Well, because their name is on it. So collaboration is I can seek the opinion of other disciplines that have seen this same patient in that 5-day window. I can
Cindy, I'm
seek
going to
their
stop you right
opinion.
there. I'm going to
Yep.
stop you right there because everybody hear what Cindy just said. I can see collaboration from people that have seen that patient. I think the
Mhm.
regulation says that makes the term that are intimately familiar or
Yes, variations of that language, that they
okay.
need to be that I am getting feedback from basically someone else who has seen this patient. Okay, so if I am out there as the admitting PT and the ADL stuff, I'm not quite sure where I land on this. I want to wait till OT goes out the next day. And then I'm going to talk to the OT and see, and we can agree. And I can say, yep, I agree with you, kind of saw the same thing, wanted to, or if I disagree, the OT can't strong arm me and get those answers changed because my name's at the bottom. So collaboration is meant to account for the fact that many of our patients are complicated. And the idea that we can get everything we need to know about them in 90 minutes to 2 hours is not going to work for some patients. So collaboration has never been, I don't feel like finishing this. I'll do my documentation tomorrow. I have 5 days before I have to turn it in. It's none of that. It is if I need additional information from the physician, from another person who saw this patient, I'm calling the daughter because I want to get additional insight from the daughter. All of that's allowable as collaboration, but I am the final decision maker, and that's why M90 date is updated to the date I made my final decision. So a clinician has to be part of this. And this is where, especially when agencies have chosen for a variety of reasons to not do a full OASIS review, they do a partial. And overwhelmingly, it's not going to shock anybody on this call. It's about payment items and outcome items. The other stuff isn't there. And so we've had clients, and then we look at it because I can't help myself. And I go over and look at the GGs, and it's like, oh my gosh, you seriously need to look at these because you're being very diligent here and you're just kind of leaving these here. And I think this is where going into E is another refreshing moment to say every item matters, whether it's outcomes, whether it's value-based purchasing, whether it's payment, whether it's stuff you don't know about yet, that data is being collected and analyzed. There's no question in there that's just a one-off placeholder of uselessness. Now, before anybody puts it in the chat box or the Q&A box, I know there's a few questions that are now stuck between D and E. It came up again in the January Q&As with respect to item 1242 about pain. That outcome is not being collected anymore, but because we are stuck with D longer than we were supposed to be, I can choose to just put an equal sign in there that I didn't collect it if I want to do that. Now, some of you may say, why on earth would I do that? Make the clinician collect it anyway. Yes, but that's an example of a question that's about to be phased out. But there's so many other items like the GGs that have a purpose, and the GGs are not going anywhere because again, they are in all 4 post-acute settings. And just in the intro call I came off today, those questions aren't going anywhere. And the math is probably already going to start changing about how these things are looked at. So we will be seeing our value, our function, and CMS is putting a big emphasis on post-acute care about the value of function. That's why they're using the GGs. And I have to say, I prefer the GGs to the M in terms of our ability to show change for this individual and the ability to use the non-attempted codes. But we have got to make sure we're doing this correctly because that's what they're going to use to make decisions about what the next evolution looks like, even though we haven't even experienced the first round technically.
Cindy, that's a great explanation. And I put up our information slide, which includes our website at www.valuebeyondthevisit.com and our emails. So if you have a hard time and you're not able to come up with your question, but you do have some questions that pop up later, as maybe if you're listening to the recording of this session, please feel free to reach out to us directly. We get back to those as soon as we possibly can. If you lose our emails, just go to our website and hit the contact button and it comes directly to me. And I also want to remind folks as we get in the last 10 minutes of our session here is that if you have any questions, to please type them into the Q&A box and we can get to as many as we can before we end. But there is a great question that came in and and this one is a deep dive. So I hope that we can answer it appropriately. Do we have any recommendations to help star ratings, M items impacted by the risk adjustment? Our raw data shows good results, improvement and risk adjustment, or our raw data shows good results, improvement, and risk adjustments knock the percentages down, thereby decreasing our star rating. Do we have any suggestions to help with that, Cindy?
We have done some work with agencies around educating the clinician about the risk adjustment items. I think it has to do with again, every item being the best possible answer from the ones that we have, in order to make sure that simultaneously with how it's coded is the best possible representation of the patient. What I'm finding when I try to dig deeper into that is we're paying attention to the item in isolation. Case in point, the ambulatory outcome, we're going to teach the clinicians all about ambulation, that 1860, how to score it, what to do. But okay, but let's think about this. Two issues. One, the risk adjustment items that influence that particular one, are those being answered correctly as well? Are they being captured correctly? The other issue is, I think sometimes, particularly to folks that are tasked with policing the outcomes, I'm just going to use that term. What I see sometimes is a very knee-jerk reaction to, if our stars, our final stars are not the way we want them, this must be an OASIS issue. And so we go back and look at the OASIS and we look at the questions and we bring people in for education again, or we've educated them to death and we're scared if we bring them in for more education, they might rise up and revolt, but we go right back to the OASIS. I want us to make sure when it comes to quality, we put OASIS in its proper place. OASIS is a measuring device. That's all it is. It doesn't think, it doesn't walk, it doesn't do anything. It's a measuring device. So let's think about outcomes like personal goals. Let's say I've decided I have an event coming up and I want to lose 10 pounds. Okay, so in order to know whether or not I'm successful, I need to have a scale, and I need to have a scale that I trust. Okay, I don't want a broken one. I don't want one that is hit or miss, because I want to know exactly where I'm starting and where I'm going along the way till I get to my final result. Because if I can't trust the scale, this whole thing is not going to go well. However, if I stand on the scale one day and I stand on the scale a week later and I don't like the number, to simply blame the scale or go after the scale is really one-sided. Again, I need to make sure that the scale battery didn't die or something like that. But an outcome is what happens between two OASIS time points. And so I see a lot of emphasis on make sure that admitting clinician scores this stuff correctly. Make sure that the discharge version of that, oh no, it came out the same. We got to do more OASIS education. Do you? Or do we need to do a better job of intentional care planning between those two time points? How are we, as an interdisciplinary team, back to the ambulation example, how are we working toward moving a 3 to a 2? What are we doing? This is not about distance, device, and level of assistance, PT. This is about, can you get them from needing someone involved, at least supervising whenever they're up and walking, to getting it to an intermittent basis? Now, maybe for some people, I can get them fully independent. That's great. But to show a change from a 3 to a 2, which gives you the same results as a 3 to a 0, I don't get bonus points. What are we doing about this? What are we dealing about with different surfaces? What are we dealing with? So we get this individual to where they're okay in their home, but they still need to be supervised on the stairs. We've moved from a 3 to a 2. So to me, Sherry, the risk adjustment items, the OASIS is what measures this. And yes, we absolutely have to make sure all of those items every time are the best possible answer. But a lot of times I see the effort to address stars be very heavy OASIS and not so much on how do I integrate OASIS into the actual care plan. Because I'm just going to call out our own profession, Sherry. I look at what PTs are focused on, and I'm not saying any of it's bad or inappropriate. I don't see it connected to those measures. I'm not saying change what they do, but why would you not be connecting to that measure? And to me, an example, and I know I just said the improvement in pain outcome is not being used anymore, blah, blah, blah. We do care about pain for our patients. And it's a great example of this clinical decision making, because we have educated for years that 1242 has nothing to do with pain assessment. Nothing. It doesn't matter what the number is. The issue is, what is this pain level doing from a quality of life perspective? How much is it interfering? And I've done countless hours of education on this with clinicians that go, yes, I already know that. They told me at the agency, I already know what this is. I already get it correct. Uh-huh. So what do your pain related goals look like on your care plan? Because when Sherry and I look at care plans, they still say pain will not be higher than 5. Patient will report acceptable pain level. Pain will decrease by 2 points. Really? Because that has nothing to do with quality of life.
Hmm.
There's nothing in here that talks about what am I doing to alleviate the interference. So I think that's where it's a little long-winded, but I think our plan of attack has been very OASIS driven and not enough about here's what the measure is, what are we doing between that? Or is it really we're going to beat up on the start of care person and the discharge person while the whole rest of the team that did the majority of the visits never even looked at the OASIS once because they were so happy they weren't stuck with it that they paid no attention to it and they didn't do the discharge. So it's a non-issue for them. To me, that's always been part of the problem with OASIS, feeling it's somebody else's job.
And Cindy, I appreciate that answer, and that is a very complicated situation, and I think you were very succinct. But I don't know if you guys heard. My dog just indicated that we're getting really close to the end of time. So I got one last question though. I want to sneak in before we're finished. Can you comment on M2020? If a medication is not in the home, an accurate scoring of the OASIS item.
Well, it seemed that that was a whole run of them in this Q&A. It was all 2020, 2030, and it was a variation on the theme. So either the patient didn't have it in the home because they couldn't afford it. The patient said they weren't going to take it. That the patient, bottom line, what do I do in a scenario when a medication is not there? What I think is interesting, again, and I'm such a geek in this respect, I like really looking at word choice. And the responses were consistent about what a clinician could do. It did not say what a clinician should do. It said a clinician can look at this situation as a whole and make a decision based on what they're seeing about this patient, what is going on related to how they're managing other oral medications or injectable medications that may already be in the home, assessing cognition, all of those things to potentially then choose a response that makes the most sense. What disturbed me about that run of 2020 questions, Sherry, is what about item 2001? Nobody connected it to 2001, and I know why. It may not be so much of a problem in 2020 because I can extrapolate from other oral medications or injectable medications or the context of this patient to determine what they need to do to manage it. But all this attention to 2020 has got to be driven in part by the fact that that's an outcome measure, management of oral medication. When missing medications may be an even bigger issue in item 2001 about is there a medication problem? Is there something going on or potentially going on with this individual related to their medication? So I see this as we audit chart, Sherry. The narrative talks about missing medication for all of those reasons. My issue is if somebody's missing their blood pressure medicine. Oh, my daughter's getting it this afternoon. Did you take what you were supposed to take this morning? No, I told you she's picking it up at the pharmacy. Is missing a medication, which missing one in 2020 puts you in response 3 because you did not take all oral doses, all of your oral medications like you were supposed to. So I would go 3 on that one. But it's an issue. Overwhelmingly, when I audit records, somehow, some way, 2001 is never, never a problem. Never, 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 no matter what the narrative says, it's never a problem. And if it is, the subsequent question is always the physician took care of it. We met
That's right.
all the aspects of the two-way communication, blah, blah, blah. Although there's no documentation to support any conversation with the physician or what happened, we have to be very careful there. I'm not saying we want to torpedo our information, but I'm beginning to suspect there's such an aversion to saying, yes, there's a medication issue because it then triggers the next calendar day issue with the doctor. But I can tell you, I have sat in the room with folks from CMS contractors and CMS on the periphery. And folks have tried to say what's wrong with that question and what's unfair about that issue because you're holding me responsible when I can't control the physician responding to me in one calendar day. And our data and love affair of downplaying the problem has led to CMS basically saying that's not a problem. You don't really find significant medication issues on the regular. And when you do, the doctor took care of it. So why would we change it? Why would we do anything when it's already working? Add insult to injury, the physician who was in the room who was telling CMS how he wishes the agency would call him more often. Well, we know that was a hallucination. But this is why accuracy, even when it's uncomfortable, has to represent the reality of what's going on. And if we're hesitant or don't want to put it when it really is, then we have created the myth that we don't find medication issues hardly ever in home care, which then I have to wonder what's with all the nursing and the med teaching if there's no risk factors. And, item 2020 is a 0, 1, or 2, which means they don't make any mistakes and there's no issues, then what on earth is 30 days plus 30 more days of med teaching being the cornerstone of the plan of care. So that's probably not what you expected, Sherry. I think the 2020 the issues in there were interesting in the Q&A, but to not connect it at all with missing medications in the home can be a real issue and a risk for the patient. I just wanted to add that piece.
And I just wanted to reiterate that we're so happy that you guys were able to join us today. And many of these issues, Cindy and I could probably dialogue for hours on as we try and come up with things that can help you in your day-to-day practice and to make things more consistent. We will be doing another Q&A in a couple months. We have stuck to that third Thursday. So our next one will be on a special date for K&K, Cindy. It's actually on March 17th. At 1
Uh-oh.
o'clock. March 17th, as we know, is St. Patrick's Day. So, before you have your first green beer, come and join us for the Q&A, and hopefully send in your questions ahead of time so that we can make sure that we get them answered. We will be sending this recording out, and we will have it available on our YouTube channel. So take a moment and subscribe. And if you have any further questions, reach out to us at our email and check out our website. Thank you guys so much for spending an hour with us, and I hope you have a wonderful day and keep fighting the fight, guys.